Alrighty, I'll go ahead and get started, and then we'll go from there. Hey everyone, I'm Rmaah. I'm one of the incoming committee co-chairs for the AWAEM GEMA Global Travel Grant Award. I have the honor of presenting both of our award recipients this year, where they'll both be sharing about emergency medicine development in their respective countries. Just to begin with, I have no disclosures. I just wanted to chat a little bit about the award itself. The GEMA AWAEM Global Travel Grant Award was created to support female emergency medicine physicians from low or middle income countries who have shown dedication to and potential for significant career achievements in emergency medicine through research, education, service, advocacy, and administration. This award provides recipients with a monetary sum to cover administrative and travel costs to attend the SAEM annual meeting. This year, we had over 30 nominations for the award, and we have 2 award recipients. So without further ado, we have our first award recipient, which is Dr. Tigist Bedane. So please give her a quick round of applause. Dr. Tigist Bedane is an emergency and critical care physician specialist from Ethiopia. She is currently working as the clinical service director at the Addis Ababa COVID-19 Field Hospital. Dr. Tigist received her undergraduate medical education at GEMA University College of Public Health and Medical Sciences in 2015 and proceeded to do her residency in emergency and critical care medicine at Addis Ababa University. Dr. Tigist has more than 8 years experience as a clinician in emergency response and 5 years experience working in a senior management role at St. Peter Specialized Hospital. Dr. Tigist is currently a Jim Leach MasterCard Fellow on Entrepreneurship at Queen's University in Canada. She is certified in Leadership and Public Management from the Virginia Tech University School of Public and International Affairs and in Project Management from Addis Ababa University. Dr. Tigist has been an advocate for emergency care both nationally and internationally. She has worked as a consultant in different international organizations and is the first master trainer for the WHO ICRC Basic Emergency Care course for the country. So please give her a round of applause as she talks about emergency medicine development in her country. Perfect. You can just click through the slides. Thank you.
Okay. Hello, everyone. Thank you for the warm introduction. Today I'm going to be talking to you about the development of emergency medicine in Ethiopia, some of the challenges and opportunities associated with it. I don't have any disclosures. Before diving into my talk, I want to tell you a few pointers or facts about my country. So Ethiopia is located in the Horn of Africa with a population of 120 million beautiful people. We are also known for our 13 months of sunshine, amazing coffee and cuisine, and also 80+ spoken languages. In Ethiopia, the initiative for the emergency medicine started in the pioneer hospital, the Tukur Ambassa Hospital. It was established in 2009, and the department was established in 2010. So before starting it, it was only started with 20 beds within the emergency unit. We also have 2 programs started for the physicians that are 3 years program, and for the MSc nurses, master's nurses program, which is a 2-year program. Prior to having graduates in emergency, the emergency was ruled by non-emergency trained professionals. So we don't have a specific spots that are assigned for resuscitation, for stabilization and the like. It was all in one room, as you can see on the pictures shown there. But in urgent cases was seen in the corridors as there was no spaces assigned for them. Later on, it was designed as having a red, yellow, and orange rooms that are for the patients to be seen. So when we come to the pre-hospital care, in most of the rural areas of the country, we depend on the people, bringing the people to the hospital. So people carry people, as you can see in the pictures, in most of the rural setup of the country. And when we come to the center, that's the capital, before 2010, there was no, only the Ethiopian Red Cross Society provided the ambulance service for the country. And it was after that the Federal Ministry of Health actually recruited many ambulances for the country, so that and dispatched it all over the country to be used for ambulance services. In Addis Ababa, the capital, most of the pre-hospital care is being given by the nurses, and the remaining of the country, the EMTs provide the ambulance service. Even though we don't have a clear dispatch center and a centralized call number at point, the ministry is working strongly with the stakeholders to establish that system. And we only have limited amount of ambulances for the country to work for emergency cases, as most of the ambulances are being used for maternal cases. So coming to disaster in COVID-19, 8 years following the establishment of the emergency program, there was an establishment of the disaster medical assistant team. And of course, once the COVID-19 hits the pandemic, I see it both as a challenge and as an opportunity. So it was a challenge, yes, since it was a new pandemic that was for the world, but in a sense of opportunity, it brought many equipments, many mechanical ventilators for the country. So it is more of an opportunity. It puts the emergency medicine faculty of the country up front. So where is our emergency medicine now? Currently, we have 5 universities that are giving the residency program within the country. The Addis Ababa University, that's the pioneer. The St. Paul's Millennium Medical College, GEMA University, Rmaah, and Hawassa. These are all for the residency programs. And for the master's nursing programs, it's the Addis Ababa University, St. Paul's Millennium Medical College, Rmaah, and Hawassa University. So until January 2023, the number of graduates for the whole country, that's 420 million, is 100 EM physicians for the whole country. And also 307 masters in emergency and critical care. We have 160 residents that are going through the program right now, and then 95 masters in emergency and critical care nursing programs. Leadership, so once the emergency and critical care residency or nursing program graduates, they all are assigned to different roles, because since it's a recent field in the country, most of them are an advocate for the program itself. So we have people in the Ministry of Health working as the emergency and critical care director, CEOs, field hospital, medical schools, ICU managers, and department heads all over the country. So it helps with the dissemination of the program to be run throughout the country. The society, the Ethiopian Society of Emergency Professionals, was established after the department was established in 2010. That's 2 years later. The composition includes the physicians, the nurses, and the paramedics as well. And this society is a member of the AFEM as well as IFEM society. So as all EMs in Africa, we are faced with different challenges. Most of the challenges are overcrowding. Since we don't have room for patients to be transferred to other facilities, we have patients that stays from hours to days to weeks within the emergency system. And since our pre-hospital care system is in its infancy stage, we see the delays in the treatment that's given. So the continuum of care will be affected in that aspect. There is also a shortage of trained professionals in the emergency. As I told you before, it's only 100 graduates of the emergency for the whole country. So there's a huge shortage of staffs. And our emergency departments are also under-resourced. Acceptance within the medical field. So since emergency started like a decade old, there is a conflict of interest between different departments. So there is, that creates a huge dissatisfaction within the team, because most of the time, the emergency trained professionals first don't have a line of growing since for fellowships and the like. And also the staffs are faced with high violence within the ER system as well, while working in the ER systems. Opportunities, the COVID-19 pandemic has been a huge opportunity in one way, and the country is also under rapid economic development, which helps for the development of the emergency system as a whole in the country. And having a young, vibrant graduates every year helps in the expansion of the ER training as well. These are my references, contact address, and as in Amharic we say "Amasaganalu," saying thank you. So thank you very much.
Thank you to Dr. Tigist for such a wonderful recap and educational presentation on the current state of emergency medicine in Ethiopia. We have one more awardee for today as well. Our second travel grant awardee is Dr. Grace Chatsika. Dr. Grace is a wife, mother of two, and an emergency medicine physician. She holds a master's degree in emergency medicine from the University of Witwatersrand, South Africa. Currently, she is the head of department of the Adult Emergency Department at Queen Elizabeth Central Hospital, Malawi, and this is the first emergency department in the entire country. She's involved in several hospital management roles, including research and drug procurement committee. She serves as a part-time faculty member at the Kamuzu University of Health Sciences, where she is in charge of emergency medicine postgraduate training. She is also involved in undergraduate training and curriculum development. Her personal interests include to improve emergency care access in Malawi, and she holds special interests in global health, antimicrobial stewardship, trauma, and sepsis. So please give Dr. Grace a round of applause for her award and her presentation.
Thank you very much. So as you've heard, my name is Grace. So I'll give you a brief background of the emergency medicine system in Malawi. So the unique thing about emergency medicine in Malawi is mostly female-led. I have no disclosures. So for you that don't know where Malawi is, it's one of the sub-Saharan countries. It's one of the poorest countries in Africa as well. And that's where it is. So at the bottom there, and that's how the map looks like. It's got a population of 13 million, and we have 6 emergency physicians for the population of 16 million. So of the 6, 4 are female. There's 1 male emergency physician, and of the 4 female physicians, 1 is an American-trained physician. And we have 1 pediatric emergency physician who's also British. We have 4 residents in training now. 2 will be graduating for the first, will be graduating our first cohort next year, and then the other 2 have just started their 3rd year. Of these 4, only 1 is female. So as you can see, of the 6 emergency physicians, there's 5 in Blantyre, so the 4 adult, the 3 adults and 1 pediatric emergency physician are in Blantyre, and the 1 male physician was sent to the north of the country. That's where he is. So the first emergency department was opened in 2011, and that was led by Dr. Nyorenda. So she's the one in a purple dress. After that, in 2016, that's when we had the first graduate. She trained in South Africa, Dr. Kata, that's her. And then I graduated in 2017. Last year in September, that's when Dr. Jerry, the first male emergency medicine specialist, graduated. So that's the faculty that's there. This is the Queen Elizabeth Central Hospital Emergency Department. So out of interest, it was, the hospital opened in 1954, and this place was opened as the administrative block. So in 2011, that's when it was refurbished to open the emergency department. So administration moved to another unit, and this was renovated to be the emergency department. As I said, Dr. Jerry was sent to the north, so that's our hope. So we have a new sun rising in the north. That's where the other new emergency department is coming up. Just letting you run through the department. So this is our emergency department. It's a 4-bedded emergency department. It's well equipped. But due to overcrowding, sometimes it can extend to 13 patients accommodating in this area. So it's quite hard work when you're working there. This is the area where we see the non-urgent cases. So orange and yellow areas are in this area. So we have the benches where the patients wait, and at the back you can see curtains. We have beds behind those curtains. That's where the patients are seen. So I put this just to give an idea of how some days are in the emergency department. So this is the male medical ward, and what you're seeing is the corridor of the ward. So the actual patients on the floor. So this part is the ward itself, so it's basically full. Patients are in the corridors, being seen in the corridors, and when this happens, it just means there's no patient moving out of the emergency department. So it will be clouded for a few days until there's patients discharged from the ward, and then the patients will move. The catchment area for the hospital. I think most of you have a few hospitals within the city, but for Blantyre itself, we don't have any other big government hospital. So this is just to give you an idea of the amount of work that's there. So this is the southern part of the district. And all these districts, so there's 2 central hospitals in the district, Zomba and Blantyre. Zomba has an ICU, but they don't have a CT scan. So most of the patients in the southern region will come to Queens for CT scan and neurosurgical services. If you're lucky, then you might go to Zomba for other services. But most of the neurosurgical patients will come to us, and some even the renal patients. So if you have someone who needs dialysis, they will come to us. Zomba is about to open a renal unit, but I think in the next few months they should be ready. But most of the patients that need more specialized care will come to us. And sometimes, if we are very pressed for ICU beds these days, we actually transfer patients out of our ICU to go to Zomba, because that's the other ICU. Otherwise, you have to send them to private hospitals, and we might not afford to pay for that. So most of the challenges we faced, as I said, this is a female-led department, actually a female-led specialty. We have a difficult work-life balance. So because of the few numbers of consultants in the department, we resorted to having a roster that you do a one-week call. So when you're on call from Monday to Friday. So during the day you're in the hospital, at night you're at home. They'll call you for any special things. If it's something that's pressing and urgent, sometimes you use anesthetist to intubate patients in the night. If they are busy as well, then you have to go in and intubate the patients. So as you can imagine, that's very stressful. And we also have academic activities. We set out Thursdays as our academic day. So we have teaching for our registrars on every Thursday. So even if you're on call, you still have to help with academic teaching. And because of that, I think most of us are lagging in our research activities. And we still have our families to run. So it becomes hectic. If you're on call that week, kids will complain at some point. But that's how life is. Support, I think we get a lot of support from the other departments, but because of the overcrowding, sometimes it may not feel enough, but they try to help us. In terms of support as well, because we have our registrars also rotate in other departments. So if they have an orthopedic rotation, they'll go to orthopedics. And because of emergency medicine specialty itself, most of the departments as well have developed a portion of emergency care in their curriculums. So also get registrars from other departments. So internal medicine surgery specialists will come for at least three months of their training to do emergency care. As females as well, most of the things that we have, the other interruption that we get in our career is maternity leaves. So I think we have 4 females, and at some point, 2 of us were pregnant at the same time. So it meant 2 of us were going on maternity leave at the same time. that was a bit hectic for the department because now the department was down to 2. But I think we worked it out well because I think it was me and Dr. Awardee, who is American, and she had opted to have a child in here instead of having the baby in Malawi. So she left a bit earlier. So the overlap of the maternity leave wasn't as long, so at least a month that the other 2 people were on the ground. But still, considering the workload, a month of being just 2 people on the ground is long. So I think maybe we should start maternity planning in the department. And then the other challenges, as I said, we don't have enough time for research, but most of us are keen to do research. So we have opportunities sometimes that we miss, or sometimes are difficult to arrange. So let's say, for example, one of us has an opportunity to do a PhD, but the PhD requires her to give 70% of her time to do the PhD. So we're still discussing on how we're going to maneuver that, so that at least she gets her PhD and the rest of us don't suffer because she's doing her PhD. So there's still a lot of things that we need to maneuver to make sure that our department is functional. I think, as Tigist said, resources are a very big issue. So I think this year has been one of the hardest years where we're running short of drugs frequently. So just to find resources, sometimes you run out of antibiotics, sometimes you run out of subbutamol for nebulization. So you still have to find other sources or just run around to find the right resources for the patients. Space, I think I've shown you the male medical ward, how full it can be. Space and since the unit was not originally meant to be an emergency department, but it was refurbished to accommodate it, sometimes space can be an issue. The other issue that is there is the referral systems. So, as I said, Blantyre doesn't have a district hospital, so almost everybody comes in. So our biggest worry is sometimes people just walk from home and say, I'm going to Queens, it's the biggest hospital in the city, so they'll be able to see me. So that causes more overcrowding. So currently, I think since August, we've opened a new unit that sees non-urgent patients. So we had a new family medicine physician join the hospital. So we took one of the COVID tents where we were using as an isolation area for COVID patients, and we've refurbished it and used as an urgent patient. So when you triage a patient and you think they are green, they are sent to that tent. So we only keep the orange and the red in the emergency department. All is not lost. I think we have achieved quite a lot. So some of the wins that we've had. So this is the team that we have in our unit. So this is almost everyone. Our clinicians, our porters, our nurses. So we had 11th year anniversary. So we had a mini function. So this is when everybody came. So this is the team that has been there, most of them since even 2011. And we've sort of bonded and we try and make things work, and things are actually working. So the other win that we have is the Ministry of Health initiatives. So currently we have 2 strategies that are being implemented. So the other one is to improve emergency care and critical care, and the other one is to improve oxygen supply in the country. So during the formulation of these strategies, that's when you note that we need more emergency medicine specialists. So the government is about to start prioritizing training of emergency medicine physicians. The other thing that happened, we don't have, as I said, we don't have an EMS system. So the World Bank had a project. So it's the Southern Africa Trade and Transport Facilitation Program. So it's running along different countries, and they established that we need care in the main roads of the country. So this is the M1 that runs from the north to the south of the country. So this is where most of the road accidents happen. So this project was looking at implementing sort of an EMS system, but it was just running from Lilongwe to Blantyre. So they bought ambulances, equipped hospitals along this road with trauma training and equipment to react to trauma patients. They couldn't train paramedics, so they took clinical officers and nurses that were working in the hospitals to be the responders. So this project also showed the need for more emergency medicine doctors in the country. So that's another win. The project came to an end, so the ambulances are still there, and they're still being run by the nurses and clinical officers that are trained. But we still need more people to join that. The other win that's there is the family medicine program. I think I've said that we didn't have family medicine in Queens, so everybody was coming to the emergency department. But as they are coming in, we're sort of taking out some of the services that we're providing to go to the family medicine specialists. So I hope as these specialists also increase in numbers, they'll also be able to get to the districts so that they can see patients in the districts, and the number of referrals coming to Queen Elizabeth Central Hospital will reduce. The other win that's there is the electronic data system. So with all these numbers of patients, we still use paper-based work. So it can be hectic, files are lost, files get wet, there's a psychiatric patient who's torn her file, and then you have to redo the work. So we are in the process of developing an electronic data system that's being sponsored by the Malawi government as well. So this will be piloted actually this year. I think by June we'll be training people to use this system. So we'll be able to register patients online and monitor how they've been seen, how long they've been in the department, what has been done for them. So this will improve the workload, and we'll be able to monitor the quality of work that's being done in the department. I think this will also help to see what the epidemiologist trains in the department. The biggest win, the training itself. So this picture was taken after the first exam that our registrars took. So as I said, we have lots of support from other departments. So as you can see in this photo, this is Professor Nyengo Nkandawire. He's a spine surgeon. He's an internal medicine specialist. That's Dr. Carter and Dr. Brady, emergency medicine specialist. That's me. That's one of the candidates. These two are internal medicine specialists. This is one of the candidates. This is an ENT specialist. This is one of Dr. Nyirenda, the EM specialist, and that's Dr. Najibo, an internal medicine specialist. So to have our practical session, we brought out a team. So we would man all the stations that we used, everybody that we could get our hands on. So that's part of the support that we get. And then we have ultrasound training. I think the Prisma group also helped us with part of the ultrasound training. So what do we need to improve our system? So we need more emergency medicine doctors, we need more nurses, we need more paramedics. So our main issue right now is sponsorship. So we have, I think, a few scholarships, but we need more scholarships to train more doctors. We need actually to develop a curriculum for emergency medicine nurses because we don't have one. This year we managed to send one nurse to Zambia to do emergency medicine specialization there. We don't have a curriculum for paramedics, but there's one college that's interested in developing one, so they're in the process of developing a curriculum for paramedics. We also need educators to train our students. So the 5 of us are not enough. Would appreciate people who would even come to just volunteer their time and teach us. In terms of sponsorship, sometimes it could be small things like even internet or just helping the registrars with their research, because they have to sponsor themselves to do their research. Thank you very much. There's one that's always available 24 hours. So we've tried to train anyone who's very interested there, so our registrars are trained. So that we've actually got 2 ultrasound training programs. So the Prisma group has helped us, and then there's another group from Netherlands. So the Netherlands group is interested in more, they were training the internal medicine specialists, but because of the collaboration that's there, they just trained everyone. So everybody, the registrars are trained to do basic ultrasounds. Our medical officers, some of them are trained, but our interns usually not trained because they also segregate in the unit. So it depends on who you're with on call, they will help you. During the day, there's usually a consultant who can do the scan for you. During the night, radiology can help, or the other registrars, so internal medicine and surgery can help, whether it's an e-fast or an e-flash.
Thank you, Dr. Grace, for discussing all of your leadership in developing emergency medicine in Malawi. Before we conclude, does anyone else have any other questions for either Dr. Tigist or Dr. Grace? Alrighty, if not, then we can end a little bit early. We can buy you guys back some time. Thank you again to both of our awardees for everything that they've done. Thank you guys, and we'll see you next year.